好，大家咁我介紹下今日個 speaker 先啦。我哋有Louis 喺度啦，我俾一陣分享佢。MRC 嘅同事啦，應該係而家叫 Advanced Practice Physio 係即係PT WK13改名 Advanced Practice Physio。咁係我諗香港數一數二多經驗去做呢個amputation management 嘅 PT 嚟。咁就因為唔係我諗唔係好多 centre 其實真係好做好多 amputation。MMRC 其中一個 centre 係more extensively guidelines 亦都有好多比較複雜啲嘅 amputation 嘅 case 都 refer MRC。咁 Louis 係主要係 MRC 嗰邊做一個amputation patient management 嘅，咁所以就應該會帶到俾大家最新啦，同埋即係至少係我哋 clinical 嘅係每天會點樣做，最 advanced 會點樣做嘅practice 會話到俾大家聽咁樣啦。咁今日嘅 lecture 同埋聽日嘅 tutorial 或者 medical section 咧都會有 Louis 去教大家嘅。咁同一時間咧，記住咧就係 technical 嘅 skills 咧，我哋今年都係會考嘅，所以咧大家都要俾心機去練，之後嘅分享都要記得練咁樣，同埋有咩唔識就記得問 Louis，就機會難逢。好啦，咁交俾 Louis 開始。
So, good morning, dear students. It is my pleasure to share my experience in the physio management for patients with amputation here. So, this is the first time I teach an MPT student. So, if you have any inquiries or any questions, you just raise your hand and ask, okay? Okay, so I'm Louis. Thank you, Patrick, for your kind introduction. So, let's start for today's lecture. Okay. Amputation is the cutting or the removal of the limb or part of the limb. So you may see on the street, sometimes you got some patients having part of the limb removed. Sometimes they sit on a wheelchair, sometimes they walk with a prosthesis. Okay, it's one of the major cause of amputation is poor circulation. So it may be due to peripheral vascular disease or diabetes. So diabetes, because in diabetic patients, okay, they may have some nerve damage due to the peripheral neuropathy. Okay, so sometimes when they have blisters, cuts, or sores, they don't know about it. So they may be unnoticed. So later on, these wounds become infected and later on become gangrene. So you have to remove it. Okay. Or it may be due to some damage of the arteries, maybe due to trauma or other kind of things. Another major cause is serious infection. You may heard from the news that some people on the streets they got the 食肉菌. Okay, 食肉菌. Okay, so that is called necrotizing fasciitis. So I've got a patient who was preparing a fish at home, and then because the fish is quite slippery, and then the fish slipped onto the thigh of the patient, and then she got the necrotizing fasciitis, and then later on got BKA, so AKA above the amputation. So if you prepare fish, you have to be careful. So don't let it fall onto your thighs. Okay. And it is quite traumatizing because when you got usually you got hurt and then you got removed, should be within 1 day, so maybe 10 or 12 hours. So after 12 hours, you have your leg amputated. So it could be very traumatizing for this kind of patient. Okay? And then, of course, you have severe trauma due to vehicle accidents, burns, or electric shocks. Okay, so like in places you have some earthquakes, serious earthquakes, you may have trapped in buildings. So this severe trauma can lead to amputation. So another cause may be you may see especially in my center, you will see is the tumor. of the bone, tumor of the bone or the muscles, what we call osteosarcoma or sarcoma. So you have to remove that part. Otherwise, you may spread to other, like the lungs or other parts of the body, okay? And I will show some videos later. Some patients will use the use of iron drops, okay? So the iron drops is the sometimes, so some patients may need it in the ICU, okay? It is the vasoactive agent for the treatment of shock. So like the patient got sepsis, may have severe decrease in the blood pressure in a short period of time. So you need to inject some iron drops to save the life. But one of the major complication is it causes vasoconstrictions of the distal part of ball limb. So usually this kind of patient, if they got amputation, they got amputated for all limbs. So I may show you the videos later. So also very traumatized. Okay, so this is the situation in Hong Kong. This is the literature on 2005, and there's another one from 2020, so a few years ago. So it's quite similar. So I just show this one. You can see the majority of the amputees are quite old. Okay, so more than 80% of them is about 60 years old. So even more than 30% is about 80 years old. So you know their rehabilitation will be complicated and difficult for them. And the indication for amputation, the majority, more than 60%, is the occlusive disease of the blood vessels. Okay, and around 30% is due to infection. Just now we talked about the necrotizing fasciitis. Okay, and some of them due to trauma or tumor. Okay, as for the level of amputation, there are more patients with below knee amputation. Around half of them have BKA. So if you have impaired circulation, it may affect the distal part more. So sometimes if you've got diabetes, usually you have below knee amputation. Above knee amputation, usually due to other causes, maybe due to tumors or infection, that kind of things. Okay, so this is just a bit, but you usually see more below knee amputation in the hospital. Okay, and the comorbid condition, usually half of them may have DM. So and also hypertension. So these things will affect their physical abilities even before they have amputation. So after amputation, you need to take care of this kind of condition as well. So we will talk about it in a later part, okay? So for amputation, you have different levels, okay? So it could be amputated through the joints, okay? So you have hip disarticulation, through knee amputation, or ankle disarticulation, or you can have hemipelvectomy. So you, like in some patients have cancers over the bone, pelvic bone, you may have part of the pelvis excised. Okay, so I've got a patient who got a hemipelvectomy. So actually the sitting balance will be affected as well, because one part, one side of the pelvis is rigid, but another part you have some bones removed. So the rigidity or the configuration already changed. So they may need some sitting cushion, because like some, maybe one side of the pelvis may drop when the patient sits. So you have to take care of the sitting posture as well. Okay, and of course you have above knee, below knee amputation. Okay, same for the upper limb amputation. So you have shoulder disarticulation, elbow disarticulation, wrist disarticulation, or above elbow, below elbow. So I've got a table. It said you've got below knee, above knee, below elbow, above elbow as older terminology, but I'm not agree with that. I think if you go to hospital, you're going to have placements there. So when you go on the clinical management system, CMS, they do it. So usually the doctors in the progress notes or in the operation notes, they will write down below knee amputation, above knee amputation. So less commonly, they will use transtibial or transfemoral. I would say, so I'm not agree that this is the older terminology, but it's quite common still using it. Okay? So when we look at the surgical procedure, so basically they trim the bone. Okay, so of course they will make it smoother, so not very sharp edges, and then they have optimum length. So what I will talk about what is optimum length later. So or in the tutorial I will talk about it. Basically they do a V shape and then stitch the end together. So for AKA is like this. Okay, the wound is at the very bottom part of the stump. So like every patient with above knee amputation and below the amputations, they will have the wound over there. Okay. Just now we talked about through the joint amputation, but if you want to fit a procedure, actually every amputated patients will got a prosthesis, 即係着個假腳或者義肢啦，我哋叫later. So you have to remember that if you got a patient with through knee amputation or through the joint amputation, actually it is not very favorable for the prosthetic fitting. So you can see this patient is having necrotizing fasciitis. So she is actually she is a through knee amputation. Okay, because maybe it's due to the which part is normal, then the surgeon just cuts to that part. Okay, so because the knee is okay, so the surgeon just saved the knee. But the problem is if you fit the prosthesis, you can see this is the good side. Okay, good side, the axis of the knee is over here. Okay, you can see. But when you look at the prosthesis, the axis is over here. So it's a little bit more distal to the normal joint axis. Okay, because this part, the knee is here, so you can't have the axis over here. Okay, so this kind of patients, their prosthesis is not fit. I mean, they have the knee axis at different locations bilaterally, so it may be a bit more difficult for them to train their walking. Okay. But because before, usually the surgeons and the P&O, 即係嗰個義肢矯形師咧, they don't have much collaboration. Now they know much better, so usually they will avoid this kind of through the joint amputation. Okay, we try to ask this lady whether you want to revise the stump. They cut but she don't want because she want her knee there. So that's so she choose to have the less favorable condition. Okay. Okay, of course, there are many physical effects of amputation. It affects the mobility. There may be stump and phantom limb pain. There will be infection. There may be infection, muscle contraction. So this kind of things is what we want to avoid. So in our rehabilitation, we try to avoid this kind of things, or at least try to maximize or minimize this kind of thing. Maximize their function, minimize this kind of effects on this kind of patient. Okay. Of course, we will see some patients acute or operatively, but sometimes they may we may see them in the pre-op stage, but if you work in the actual hospital, there may be some patients who are not urgently cut. Like if you have necrotizing fasciitis, it's an urgent operation, so you can't have the pre-op phase. But some kind of conditions, maybe they've got diabetes, they may have clinical admitted, means that not urgent, just you have a certain kind of day you admit to have that kind of amputation, then you may have the pre-op rehabilitation. Okay. Of course, after the acute post-op, you go into the pre-prosthetic stage. So later on, when you have the prosthesis, you will have the prosthetic training phase. Okay, so we will talk about this a bit later. And later on, we will go into the community reintegration or vocational rehabilitation phase. Okay. So let's look at what we do in the acute and subacute post-operative phase. Now, of course, one of the major things we will do is the functional training to deal with the back mobility and transfer, and also teach them to walk and use the wheelchair. Okay. So this is the mobility training. It can be done on the first session. Usually, you will see the patients in the back side. So back side. Okay. So this kind of patient you seldomly see because this is the bilateral amputee. Okay. Usually they have unilateral amputation. Seldom they will have bilateral amputation unless you've got necrotizing fasciitis or other kinds of like iron drops things. You will have bilateral. So this kind of patient, you need to teach them to, of course, use the upper limb to push, okay, do the trunk rotation and the thrust of the upper limb, the remaining stump, pushing downwards, so to get up by him or herself, okay. But this one, bridging, of course, is much more important because it's the most functional part for this kind of patient. If you want to go to the toilet, if you in bed, 你如果去實習咧，佢哋要去大小便咪攝個坑入去嘅 then they need to do the bridging. Okay, so you have to teach them as soon as possible. 如果唔係咧，去廁所都好難。咁所以 so that means usually I will teach them, at least check whether they can do it on the first day. I will check whether they can do the bridging. Okay. And of course, if they got a wheelchair, okay, you can teach them how to transfer, because in our hospital, they go down to the department for training. So you won't, you need to transfer the patient to onto a wheelchair so as to transfer the patient to the department to have the rehabilitation. Okay, so usually we will transfer the patient to the good side. Okay, so this patient move towards the good side. So I will talk about it in much more detail in the tutorial tomorrow. So there are some steps that you have to take care of. So have to effective transfer. Okay, and in some patients they may use a transfer board or a sliding board. So this board is actually very slippery and then very flat. Okay, you just sit into the buttock of the patient. Okay, and then the patient may be able to transfer by himself or herself. So because it, the major difference is in this transfer you can't sit in the middle. 即係你坐喺度咧，咪坐喺個轆上面唔得㗎嘛，揞住佢。But on this transfer board, actually you can do it bit by bit. So you can actually sit here. If you feel tired, you just stay there 1-2 seconds, take a rest, and then complete the transfer later on. Okay, and of course for bilateral lower limb amputees, you can teach them forward and backward transfers. So just put the wheelchair facing the plinth and then use the hand to push. And then once pushed, then the buttock move towards the plinth. Okay. And other than the transfer, we will teach the patient walking. So this is our main duty, isn't it? Okay, so this is the training of an amputee. So doing some single leg training in the parallel bar. Okay. Actually, it improves morale because some patient maybe few days or 10 days without standing up. So doing this may improve their morale. Okay, and then they will get used to the change of the gravity. What I mean is, if it's amputated, okay, this side, then the center of gravity will shift towards the good side. So they will have a change in the center of gravity. So they need to get used to it. And then even if they have a prosthesis, sometimes they will walk without any prosthesis. Like during nighttime, midnight, if the patient want to go to the toilet, you won't actually put on the prosthesis and then go to the toilet and then come back and then take off the prosthesis because it takes time. So sometimes they will just hop with a frame to the toilet and then come back and then go back to sleep. Okay. And standing is important for measurement of prosthesis. Okay, I have a diagram. This one show how to measure the prosthesis, measure the socket size of the prosthesis. But this one is wrong actually. They won't do it in supine line. They will do it in standing because if you do in standing, if you do in supine, then the stump shape is different because this part, due to gravity, it will drag down. Okay, so it's like this. Okay, 即係話你瞓喺度，佢下邊嗰 part 咪揼咗落嚟。Actually, it's not the same. The size is not the same, or the shape is not the same when you compare in standing. So actually, in our hospital, they will do the shaping or the measurement of the socket. 即係佢哋個架腳有個 socket 咁套落去啫嘛。咁你 you have to have the good size. Okay, if the size is changed, then once you put on, actually it's not the same in standing, so it's not very optimal. Okay, so you have to have the patient at least able to stand. Okay, some patients really can't stand, maybe can stand only 30 seconds. So that kind of patient cannot measure the prosthesis. So you need to train them with their standing tolerance. Okay. So of course, we gradually increase the difficulties, start by standing, and then single leg hopping, later on walk with a frame or hop with elbow crutches. Okay, another major role is for us is the exercise or the range of motion training. Okay. So this is the patient. I usually ask them to do prone lying so as to stretch the hip flexors. So even more true for patients with above knee amputation. For above knee amputation, usually we need to take care of the hip flexor. So because when they sit there, the hip flexor is shortened. Sometimes it becomes contracture later. So if you have a patient with AKA, you must teach them to do hip flexor stretching. For below knee is the hamstring. Okay, so this is the major thing we need to teach. So if the patient have hamstring tightness later on, then everyone know that we are not doing our job. Okay, so you have to remember this. Okay, and then sometimes we will do the passive stretching for them, or sometimes we do strengthening exercise of the muscle parts. Okay, so like the hip flexor, we may train up the hip extensors. I mean, some strengthening exercise to the hip extensors, okay? The antagonistic muscles. Okay, these are the position that we may ask the patient to do. So this is the stretching of the hamstring. Actually, it's the same for other kinds of stretching. For the hamstring, you just need to keep the knee in a straight position, and of course, you need to have a flat back. So just the whole back push downwards so that you stretch your hamstring. This is the stretching for the hip flexor, but I seldom ask the patient to do this because it is not a very stable, I mean, I don't want them to put in this risky position, okay? So I will ask them to do prone lying or do something like the Thomas test, okay? So I may even help them to stretch the hip flexor. Okay? But this is not, you should, sometimes if you're on the back side, you can't hang the patients towards the end of the prim. So this is in the department, we can do this. In the ward, okay, sometimes I will just ask the patient to do side lying and then do the hip flexor stretching in side lying, okay? Of course, we ask them to strengthen all the directions. Gluteal contraction, very important because once they have the prosthetic training, they need to have at least they need to contract their gluteal. So you have to start the gluteal contraction earlier, okay? Because when like above knee and like for above knee amputation, actually the knee joint, you cannot control the knee joint. So actually the prosthesis, if you put forward, you are using your buttock to lock the knee joint so as to walk forward. Okay, so that gluteal muscle contraction is important for this kind of patient. So make sure you start this as soon as possible, okay? And then of course, bridging exercise, hip hiking exercise, okay? All directions, hip flexion, and hip extension in prone leg. Sometimes I just ask the patient to do prone positioning, and then I will ask the patient to do active hip extension, okay? At the same time, can do at the same time. And this is a patient with hip disarticulation, a young gentleman. We may also train up the trunk muscles, okay? Okay, some bridging exercise. So this one, actually, there are some therapeutic about, so assist the bridging, okay? And of course, we must not forget the cardiovascular training. Why I said so? Because some of them already may have poor cardiovascular condition. So you remember many of them have diabetes, okay? Diabetes already, their physique is not very good already, okay? But if you see on this graph, actually you have to ask them to have around 50% more of energy expenditure. So if already they are in poor condition, you need to ask them to have 50% more energy expenditure. This is very difficult for them. So we start as soon as possible. Otherwise, if you have the prosthesis, you don't have the physique or the endurance or the aerobic ability, then the patient can't train very good. Okay, so we have to start. Usually we use the upper limb ergometer. So because the limb is amputated, you can't do the lower limb ergometer. So we will use the upper limb ergometer. At least I will start whenever they go to the department, I will start this exercise for them. Okay, and another major role of us is desensitization or the stump or the pain management. Okay, so this is the ideal stump shape, the ideal condition of the stump. Okay, so cylindrical or what we call taper. Taper 咧尖尖嘅，即係上面闊，下面窄嘅。因為你調翻轉下面闊，上面窄咧，即係佢會腫㗎嘛下面。So it's difficult to put on the prosthesis. So you have to have it taper so you can put on the prosthesis socket in. Okay, so taper or cylindrical. Without contracture, normal sensation, subside edema, and normal sensation. So usually it's not like that. So from problematic, we try to use our interventions, try to be the condition of the stump as ideal as possible. Okay. I would say the edema control is the most important in their intervention. Why would I say that? Because the edema will affect the time of their prosthesis measurement. 即係話佢幾時度隻假腳就係要佢總 control 得好先度啊嘛。Why I said so? Because if you have a very swollen stump, so if you measure the prosthesis, when you later on, because the swelling will go away or decrease. Okay, when you measure in a very swollen condition, and then later on it becomes less swollen, then the socket is not fitting well onto the stump. 即係佢會甩出嚟或者佢會鬆啊嘛。因為你 if you do it in a swollen, then the socket is larger. Okay, then later on the stump shape become less swollen, then it's not the same shape as when you are measuring. Okay, so if you have quicker edema management, I mean, the edema can decrease as quickly as possible, then they can have the prosthetic measurement as soon as possible, then they can go back home as soon as possible. Isn't it? Okay, so this is how we manage the stump, the edema. Okay, so this is the stump bandaging. Have you heard of stump bandaging? So you will know that because it may be in examination, so you have to be careful. And we will talk about this in much more detail. So if you see like this, is no point because it's just like cross here, cross there. I will show in the tutorial. Okay. Okay, but another thing is hold on. Okay, so the few thing is you can put on a rigid dressing. So I will show you what is rigid dressing. Soft dressing is the okay, so you do it in a particular way, okay, or a shrinker. So this is the shrinker, okay. So like this. This one I would say this is not the ideal because this part is thicker than the upper part. So when you put on something compressed onto the stump end, it will go back to the better shape. Okay, and then because you compress, then actually you are shaping the stump end to a more ideal shape. Like this is not really taper, but at least it's cylindrical. Okay. Okay. Or we can do some compression therapy. So this is the infrared we are using in MMRC. So it's basically 12 chambers, and then you put pump air inside this 12 chambers in a sequential way. So pump in here, and then you just like pushing the edema away from the distal to the proximal. So you go back to the more central part. Of course, the distal part, you amputated, the leg is not inside, so you are mainly compressing the proximal part. Okay? So this is the measurement of the proximity. We talked about this already. So this is the rigid dressing. Rigid dressing is for BKA only. I'm not sure whether the notes is wrong. It should be BKA. Okay, AKA you won't put on a rigid dressing. BKA it is 其實係個石膏嚟嘅。Okay, this is the plaster cast pass through the knee joint. Okay, of course inside there are some cotton pads. Okay, and then it passed the knee joint and onto the distal part of the thigh, mid thigh sometimes. So this is the real rigid dressing. Usually they have a date onto it. Okay, this is like because they won't put it for 12 or 15 days. They will in the middle. This is the protocol. Usually they put on the rigid dressing for a few days. Like day 9, they will cut it off and then have a look, because if you put on the rigid dressing, you won't know what's the condition inside. So from the day 3 to day 9, usually they would cut it out and then observe a little bit what's the condition inside. If they need another rigid dressing, they may put it back and then for like 10 to 20. Okay, but if you think that the condition is not very good already on day 9, when you cut it out and the wounds deteriorated, you will put on the rigid dressing again. So this is because they just cut out, they need to assess. Okay, some patient may not have the second rigid dressing. So why we put on the rigid dressing? It can decrease the swelling in the stomach because it's compressed, okay, in a rigid way. Okay, so it decreases the time between the amputation and the fitting of prosthesis. Okay, and of course, because you remember the wound is at the bottom part of the stump, if you have a rigid dressing, okay, so you are not able to touch the wound from outside. So it improves the wound's healing, and then it will reduce pain, because later on we will talk about the pain. If the patient got phantom pain or some pain over the stump, pressure can help to relieve the pain. So this rigid dressing actually provides some pressure, okay, some compression, okay. And of course, they can progress more quickly. Like in this side, this prosthesis is you have the outside part only. So if you think this patient, this part, okay, tuck into here. Okay, so the patients can start weight bearing at a very early stage. So it can be as soon as few days. Okay, if you don't have rigid dressing, you compress on the stump. Okay, the stump, the wound is over here. Okay, you got. So if you put on a socket, actually it's like 好似搣橙咁樣抹開咁。咁但係你有個 if you have a rigid dressing, you are very safe to put into the temporary prosthesis. This is the temporary prosthesis. Okay, so can start weight bearing very early without damage the wound at the very bottom part of the stump. Okay. Of course, you can't inspect the wound, or you can't have daily dressing onto the wound. So you have to choose some smarter patients. If you've got the patients with severe dementia, okay, so you won't put the patient into that kind of rigid dressing, because the patient can't tell you I have discomfort. Okay, once you open, oh wow, so many pressure points and some I've got a patient who was having rigid dressing, and then after the cut out at the first rigid dressing, okay, he got like the $5 size of wound over the patella， 即係有個 pressure sore 喺個 patella 前邊嗰度。Then he actually need 2 months to get that area to be healed. Okay, because if you measure prosthesis, you need to have the whole stump in good condition without any wound over there. If you have wound， 即係其實佢點樣度就係佢 the piano put plaster cast， 即係其實你擺個石膏落去咧，咁佢就攞咗佢個 shape 出嚟。咁跟住咧，你拎翻出嚟，裏邊嗰個咪就係佢個 stump shape。所以佢係 so that's why the piano need to put on a plaster cast onto it and then pull it out. Okay, if you have a wound, you just pull the skin out. So you can't have any wound. Okay, so but if you have the wound over there, you have to delay the measurement. So the patient will get home a little bit late. Okay, I mean, will postpone the the date for home. Okay, and in MMRC, now we have this kind of extension splint. Okay, but we have to be careful because this extension splint, some patients put it 24 hours a day. So after putting 2-3 weeks, I've got a falling to amputation in Queen Mary, put on 24 hours for 3 weeks. So you can imagine how stiff the knee will be after this rigid dress. I mean the extension split. So sometimes we just ask the patients to remove it and then move it by the patient, not to put it 24 hours on one day. Okay. Okay, stump bandaging. Maybe talk about tomorrow. So go into much more detail. But this is important. Stump bandaging. You need to put on the stump bandaging onto the patient to control the edema, and later on the patients can do the self bandaging. Okay, 自己紮啦。You have to teach the patients to do that. Okay, so up to this point, any problem? Okay, so let's continue. So let's talk about phantom pain. So phantom pain, sometimes we call it's different from phantom sensation. Okay, phantom sensation means the brain still think that the limb is there. Okay, 我哋同啲 patient 講係鬼影腳。That's phantom sensation. Okay, phantom pain is pain over that area already cut. Okay, so sometimes the patient tell you, oh, I've still got pain over the ankle, but the ankle already amputated. So how can you help the patient? We will talk about this later. It affects up to 80% of the amputees, more commonly in women. Okay, sensation of pain in the missing limb. Okay, phantom sensation. We also need to remind the patient, because if the patient, like sometimes they still think the limb is there. During nighttime when they go to the toilet, sometimes they get up and they want to weigh bare on that amputated leg. So, but the leg is not there, so they may fall due to that phantom sensation. So you have to remind them, if you go to the toilet in the middle of the night, you have to aware that your limb is not there already. Okay， 即係有啲就係起身想 weigh bare 冇隻腳唔喺度啊，咁咪跌咗落嚟，係啦 ，it's in the ward. And then the phantom pain can be due to peripheral factor or the central factor. Okay, because when you do amputation, you really need to cut the nerve endings. Okay, so after cutting it, the nerve ending will regenerate. So it will regenerate in disorganized, so it's become neuromas. Okay, so it could be very painful. Or another theory is learned paralysis, because the brain still transmits some motor commands to the limb, but the brain, but the limb cannot move. Huh? Okay, the brain perceives the limb as paralyzed, and then it become an illusion of paralysis as a sensation of pain. Okay, this is called learned paralysis. Okay, how to deal with it? We have some new surgical techniques to deal with it, or we can use mirror therapy. We will talk about the mirror therapy. So this is the phantom sensation or phantom pain. So if it will fluctuate, like in colder weathers, in like nighttime, usually the pain is more severe. Okay, but when we talk about the relieving activities, actually we can use these activities to help the patients. Like in hot weather, is usually less painful. After exercise, more less painful. Touching the stomach, less painful. So we are using this as the desensitization techniques we will talk about later. Okay. Of course, we do some. The surgeon will give the patient some medication, but sometimes it could be very painful that need to consult the pain team because very painful. It could be very painful. I've got a patient who got amputated for like 8 years. Okay, so when the surgeon assessed the patient, the surgeon just want to touch the patient, and then the patient just stop, and you can see how painful it is. 8 years already, so already taken many painkillers, but still could be very painful. Okay, so that's why she later on undergo the newer surgery, but I will talk about later. Okay, it's called the targeted muscle reinnervation. We will talk about in the later part. Okay, of course, use the prosthesis will decrease the phantom pain because, as I said, compression actually decrease phantom pain. So using the prosthesis actually means compressing onto the stomach. Okay, so it's good for the phantom pain. Okay, mirror therapy also. What is mirror therapy? Mirror therapy is doing the just sit in front of the mirror. Okay, so the patient will look at the good side from the inside the mirror. Okay, so the good limb, when the good limb moves, watch the reflection in the mirror. Okay, so watch here, then it appears that both limbs are moving. Okay, actually it's tricking or cheating the brain. Okay, did you 你哋有冇睇過 IG 有段片 ？Okay, so the one man with a hammer, okay, and then just put up the good limb at the side, okay, put a plastic limb over here, and then when you try to hammer it, okay, yeah, and then it's quite scary for that patient. Actually, the brain can be cheated, okay, like in that situation, you cheat the brain. So this is the same kind of idea. You are cheating the brain, okay? Actually, you just stop the learned paralysis. You tell the brain, oh, that both limbs are intact, is functional, okay? So it really will decrease or resolve the pain because that pain is cortical. Due to the cortical things, you do some local things, you can't really control that the pain from the central mechanism. Okay, so this is central pain memory and then peripheral factors. Peripheral factors we can do other. The central pain we need to do it centrally. Okay, we have the cortical reorganization over the brain by doing this mirror therapy. Okay. But for local intervention, it could be these few techniques. Of course, you ask the patient to do some self-massaging, okay, some tapping, but it's not how to ask the patient to tap. 有時咧，我見啲婆婆咧咁啊冇用嘅，即係其實你掂下啲 skin，你梗係要打落去，即係你 ask the patient，你 demonstrate 咧，即係要打落去。Of course 即係佢哋咧有時咧話係驚整到個 wound 啊咁樣，其實你唔好拍落個 wound 度得咯。And then do some self massaging. Okay, you're not actually opening up the wound, then it's okay. Okay, can massage other parts, especially the painful parts. Okay. And then the towel pull. Okay, towel pull means you just give the patient a towel and then you put it at the distal part and then you pull it. So this creates some compression onto the stomach, okay, and then it will decrease the pain. And of course, desensitization is another area we want to have by using a brush. Okay, this is brush. 其實就揾個 brush 啫嘛，你即係起個 brush 嘅，唔好咁大力咯，係啦。And if there's no brush, you just give a towel. The towel is rub. Okay, so you just ask the patient to rub the distal part. Okay, so of course you control the amount of force you are using. Can be use a rough texture. 有啲咩咧？其實啲毛巾咧，呢啲醫院毛巾好粗噶嘛，俾佢啱嘅。咁實質其實即係唔係啲摸落好滑嗰啲即係醫院嗰啲咧新嗰啲就硬啲嘅，洗過一次咧淺色啲咧就難啲嘅，所以兩樣都有係你揀條新嘅，揀條舊嘅得㗎。係啊。Okay, so this summarize the what we do for the skin desensitization. Okay, so tapping, massage, scar mobilization. Scar mobilization, if the wound is healed, you can do some diffractional massage so as to improve the flexibility of the scar. Okay, towel pull. Sometimes I will use TENS. Okay. Okay, so this is what we came across. So the major thing is edema control. Okay, if the patient have better edema control, then it could be they have quicker. I mean, they will measure the prosthesis quicker and then can go back home quicker. Okay, so you can imagine for diabetic patients, this is even more important for with proper stump bandaging to improve the stump shape and the stump size, because for diabetic patients they have poor distal circulation. Okay, so this is what we do in the acute phase. Of course, later on in the pre-prosthetic stage, we still do the same. Okay, so what we do is pre-prosthetic means before we have the prosthesis, 即係隻假腳之前. Okay, so we can ask the patient to do some pylon or pneumatic pylon training. So what we mean by this is basically a rigid frame, then with inflatable socket over here. So you put on the socket, put on this bag and then this rigid frame, and then inflated it. Then the patient can walk. Okay, it's called pneumatic post-amputation mobility aid. We will have a look at it during the tutorial session. Okay, so this is we ask the patient to do stepping. But actually, this is weight bearing onto the stomach. Okay, and a stepping exercise before day training. Okay, how about the prosthetic stage? So when the prosthesis is ready, we go into the prosthetic training phase. So the one of the most important thing is the patient needs to have good skin integrity for any weight bearing. If there is any wound, even very small size, you have to stop the prosthetic training because if you have this because already their skin not very good, okay, the condition not very good, you put on more pressure or more abrasion over there, then the wound may become even larger and then need longer time to heal. So once you got the skin problem, you have to stop. Of course, before we do training without the prosthesis, later we prosthetic stage, we use the PPAM 8, and then with the temporary prosthesis, and then some tailor-made prosthesis. This temporary prosthesis can be as early as just now we mentioned when the patient have rigid dressing. That one is temporary. They won't take that prosthesis back home. So, but this is the tailor-made. They will take the prosthesis back home, okay, for home use or for community use. Different level, different kind of prosthesis. Like what I said, a patient with hip disarticulation or hemipelvectomy, the prosthesis is like this. Okay, so it's enclosed the hip joint. Okay, if it's about knee, then it could be longer or shorter, and have different kind of weight-bearing mechanisms. But before they measure the prosthesis, usually the P&O or us will use the AMP. AMP is 5 level from K0 to K4 classification. Actually, is like a scoring system. This is quite small, but it measures 21 functional tasks, and then it will have a score. Not sure whether you can see. Actually, K0 means very low score, and then K4 means higher score. You just know K0, K1, K2, K3, K4. What it used for is mainly for the prescription of the prosthesis. Like in a higher level, or I mean the more like K3 or K4 amputees, they may have a better or more mobile prosthesis. Like in the very basic the prosthetic foot, okay, is rigid by itself. Okay, you won't have any movement for the ankle joint. Yeah, but of course, if you don't have any movement over the ankle joint, then the walking gait is less functional, or less ideal. Okay, but like in the K3 or K4 amputees, they have much better functional abilities. The P&O may prescribe a more mobile, like can have dorsiflexion, plantar flexion, or even emergent kind of prosthesis. But if you have a very old gentleman, like 90 years old, you give that kind of prosthesis, 即係賺啲嘅，係咪？咁所以就that kind of patients like K2 or K1, they will give a rigid or less functional or less movement is better because stability is more important for them. Okay, so this one actually is related to the prosthetic prescription choice. Why is it important? Because in every Hong Kong citizen, if you have one limb amputated, the government will provide you with a prosthesis free of charge. Okay, 即係每一個 if you have bilateral amputation, you have 2 prostheses. If you have 4 limbs, then you got 4 prostheses. Okay, but of course that the money is from the government, so you have to justify why you give a better prosthesis. Better prosthesis mean it's more expensive. Okay, so if you give better prosthesis, you have to justify. So this is the K level, is a good justification. Okay, so K3, you give a mobile, more expensive ankle joint, then it's justified. Okay, so K0, you give a mobile ankle joint, not very justified. Okay. Okay, so K1 means limited household ambulator. 0 actually means not functional. Even if you give prosthesis to them, they are not able to do any walking or even standing. They can't do. Okay, so K3 some barriers, but can the exercise activities beyond that simple demand. Like in I've got a patient before is K3, and then he is a 啲片場嗰啲打燈嗰啲師傅咧，that means he need to like carry heavy things, need to squat down and then set the lamps. I mean the lighting. Okay, so that patient got a K3 and then he can use it and then function quite well. Even he can go back to his work. Okay, but K0 don't means you don't give a prosthesis. It could be cosmetic. Cosmetic means that not functional, but like if you go out for for shopping, then you have a if you put on the trousers or put on the shoes, then sometimes you don't notice that they just sit on the wheelchair, but you may not notice that they are an amputee. Okay, and this is the basic component of a lower limb prosthesis. There is a liner inside, and this is the rigid socket. Okay, a liner inside. I bring along a prosthesis I will show you tomorrow. Okay, this is also like this. 有個 liner 喺入邊 foam liner. Okay, and this is the rigid socket. Sometimes they have a belt to fixate onto the thigh, so it won't fall off. Okay. The majority of the patient is having patellar tendon bearing socket for the below knee. Okay. Actually, the patellar tendon bearing is still quite painful for them because you put nearly the whole body's weight onto the patella. So I should say is usually is total surface weight bearing. It's total surface bearing, not patella tendon bearing, because patella tendon bearing is quite painful. You put the whole body's force onto the patella tendons, sometimes quite irritating for them. So usually they do the total surface bearing. Total surface bearing means they may have other parts like the condylar area, as well as the patellar tendon area. So it's more comfortable for the patient. But of course, we need to avoid the sensitive area. Okay, so this is the red. Actually, you don't need to remember all the things, because once you take it off, you will check the whole area. This is mainly for the P&O. P&O need to avoid the weight bearing onto this sensitive area. You won't press onto the patella if you put on the prosthesis, of course, isn't it? It's painful over there. It's sensitive, and then also it's foamy over there. Okay, so they will try to shape the liner. 頭先咪有個 liner 嘅啫，呢嚿嘢 this one can be shaped because it if you use a 即係佢係如果熱咗咧，佢會可以個 shape 可以轉嘅，即係佢哋揾個風筒咧咁樣吹熱咗佢咧，咁跟住咧，譬如呢個 so press this part into then 我用中文嘅，即係話其實佢呢嚿嘢咧係一嚿好似即係蝦片式嗰樣嘢係腍腍地嘅，但係咧佢用嗰個熱槍咧咁樣吹佢咧，佢係會可以變形嘅。咁點解佢 why the patient need to weight bear if the patient want to weight bear on it so the piano just press 即係熱溶咗佢擺落去咁樣推落去，咁佢呢度咪壓住個 patella tendon， 咁佢之後咪可以喺呢一度 weight bearing 咯，明嘛？即係 so this is how they shape the liner. This part, the socket, the real socket is very rigid and very hard. So you won't be able to shape the outer side. So you just shape the liner. Okay. So that's why 點解呢個凹咗係因為我 shape 咗，咁佢喺入邊又凹咗落去，咁我喺嗰度就可以 weight bear。Okay, so this is just have different suspension. So this one supracondylar or suprapatellar. So more some force is transmitted through here already, more stable. Okay. This one not less stable, so need to have some need a belt. OK， 即係綁條好似皮帶咁樣，即係頭先呢條係啦，綁住咁咪就 fix and can be fixed onto the thigh. Okay. Actually, this for the AKA, what we need to remember is whether the socket is ischium weight bearing or containment. Because this is important. Sometimes if the patient, the ischium need to be contained into the socket. 即係你有時個 patient after putting on the prosthesis, the ischium is not inside the prosthesis， 可能佢擠住出嚟，即係啲肉咧，即係佢哋啲肉頭啊，擠咗出嚟 ，not actually weight bearing on the prosthesis. Then the prosthesis is not put on properly. Then actually the patient cannot weight bear. Okay, so this is more practical. When you see the patients, you will know what I'm talking about. But if it is larger in size, make sure this part also put inside. Here, it's only sit at the rim, okay? More mobile, but more comfortable. This one, less comfortable, I think. It's like this. Okay, this is ischial containment socket with a pelvic belt. Okay, pelvic belt is a belt across the pelvis. Okay, and then it is lock knee. Okay, this is not a very like I think this is like a K1 kind of patient. So the knee is locked. Okay, so usually it's walked. Then it's walk like this. Okay, it's locked. Okay, so not very you will be very easy to see, because if you give mobile knee, the patient may give way, so it's walk like this. Okay, so when step forward and control the knee, unable to lock the knee joint. Once he put another leg forward, then he buckle. This leg will, the prosthesis will buckle, then the patient will fall down. So for this kind of patient, we will give a lock knee. Okay, that doesn't mean that the knee cannot be unlocked. So there is a switch over here. Okay, a pull 即係佢有條嗰啲威亞咧，咁一掹咧，其實 the knee joint can be unlocked. So if you go out on the MTR, you won't sit like this. Okay, 你都要 unlock 佢，等佢隻腳收翻落去咪。But when doing walking, you lock the knee. Okay. Okay, lock knee for frail patients, poor stability, free knee, more normal gait. Okay, so other designs, that is pneumatic, hydraulic, microprocessors knee. Okay, so these are more fancy things. So anyone would guess how much the most expensive prosthesis you got in the market? How much? 大家估下，100,000手都唔係，係咪話100,000？I mean the most common, the most basic is around 15,000度啦，最 basic 嗰啲40都未夠。所以最貴啊！你差唔多啦，仲10幾萬。係啊，咁咧係啊，that is microprocessor knee。Okay, 即係比較好慢嘅。Microprocessor knee means that actually it have feedback and then maybe able to control. Once you feel you have lost balance, it will lock by itself and then protect you. And then when you sit down, 咪要揾到個客先啊！你都要記得我一定嘅。不過都唔係我哋做。But another thing is if the patient sit down, okay, it's like 啲巴士埋站，then the microprocessor is also like that. Okay, can be used for 5 years. Okay. 12萬。冇sensitive, but sometimes they 都好有錢㗎嘛，有啲即係真係可能maybe some patients have some injury, okay, injury on duty or traffic accident, they may have some compensation. So maybe this kind of patient will be able to afford this kind of prosthesis. Okay. So this is what I talked about before. How to control the knee joint with the prosthesis about knee actually is using the hip joint. Okay, if you like stand up, you want to flex the knee, you just do the hip flexion. Because the knee joint you can't control. Okay, you flex, and then if you want to extend, you basically ask the patient to compress onto the prosthesis. Actually, it's the hip extension. Okay, you can press on here, then the knee is locked. Okay, if the hip is not contracting, the knee is flexed. So contract, extend the knee, lock it, and then walk with another leg. Okay, so basically they control with the hip joint. So that's why bridging exercise or gluteal contraction is important, because if they like 2 months without using the hip extensor, then it can be very weak. Okay. Oh, this is the patient. This is the patient I just talked about, the case 3. Okay. So the knee joint is movable. Okay, multi-axial. Okay. That means this one more expensive than the more basic one. Okay, so after the prosthetic training, you need to look at the pressure sensitive areas. Okay, if you're talking about greater for above knee is the greater trochanter and the pubic rami. Okay, so here and here. Okay, this one actually you won't be able to compress with your prosthesis. This is sensitive part, but usually you don't need to check because it is not covered by the prosthesis. Of course, the ischium tuberosity is also weight bearing, but it's not pressure sensitive. But you may also need to check, but that is not the pressure sensitive area. Okay. Also, why we need to check? Because sometimes there may be abrasion, especially for patients with the prosthesis not fitting good enough. There may be some relative movement of the stump and the prosthesis. Then there are some friction. Okay, some friction will cause abrasion. Okay. Just now we talk about ankle, rigid ankle. This is the most basic kind of foot. I've got the prosthesis I will show you tomorrow, the sack foot. The most basic, okay, solid ankle cushion heel. Okay, for upper limb, actually upper limb prosthesis, not very functional, I would say. Patient usually won't use it. It's like if you want to drink water, okay, the prosthesis like this one in the middle, okay, it's like this. So you, okay, and then grab, okay, and then take it to your mouth, okay, and then drink. Okay, and then put it back. Okay, release. Okay. But you have a good hand. You can do it in 1 second. So why would you spend 20 seconds to use a not very functional prosthesis to drink? Isn't it? So there are some tasks that may need both hands. Like 你切橙係咪要兩隻手先？但係 but will you put on the prosthesis and then do the 切橙? I don't think so. So usually they won't put on the prosthesis. And even if the upper limb prosthesis is, I would say your upper limb also have weight, isn't it? 即係都有重量㗎嘛。其實可能個 prosthesis 重啲啲， but they usually will perceive that prosthesis as very heavy because it's not part of your body. Like few kg, they said very heavy. And then another thing is in Hong Kong, you know, it's very humid. Okay, so after putting on, you go outside and all the sweat is inside, so not very comfortable. So usually they won't wear it. Okay, because in Hong Kong, very basic upper limb prosthesis, just like the middle one. Okay. But there are some advanced models. Okay. This one, 30,000 euros, 10,000 to 30,000. Okay. But you need to, this is called the myoelectric prosthesis. Okay. It is much more functional, but you need to train up how to use that because, like here, you are using different muscles. I will talk about this later. So 一陣我再講呢個，譬如講一個手術，你哋就會明。Okay, so this is the hip disarticulation patient. You can see actually the knee joint 有啲彈性嘅，係咁樣。嗱，佢屈咗之後咧，佢會彈出去。跳躍咯，係有個彈弓喺度嘅。Okay, why is it like this? Okay, so if the patient have that do not have that kind of design, so after weight on this side, how can you swing this back leg to the front? You need to use your trunk. You need to do it like this. That design is you step the good leg forward, the back knee is flexed, okay? Flex a little bit, and then because you have the spring, you release it, it will bounce to the front. Okay, so you won't need to use your trunk to propel the prosthesis to the front. 因為咧好快要不同嘅。So this is through the track for cardiovascular training. But actually, this is not using the 即係唔係用咩彈，佢係自己遞嘅咋。Okay, stepping exercise. Before we go to the stairs, we do it in the parallel bar. This one also has the spring. Okay, this is the four limbs amputee. You can see the fingers are bilateral amputee. Now in MMRC, there is another four limbs amputee. Wrist disarticulation, this one below elbow, bilateral BK, so very demanding. This is the annual drop state. 都係打強心針，救翻人命就 four limbs of me. 10 years I saw around 4 to 5 patients like this. So this lady is 87 years old. The main wish is she can walk indoor few steps. So this is how she achieved. Okay, in MMRC, that lady was 60 years old, still quite young. So I don't think she can go out. Even this patient have two helpers, 兩個工人. So that's why the caring is okay at home. My patients now only got a brother, 佢係女 patient， 有個細佬。You can imagine how difficult it will be. After toileting, going to clean. 即係你冇理由叫細佬幫佢 clean 㗎嘛。Even after toileting, you need to be taken care. So need full-time care. This must be full-time care. But that lady, not very well off. So it's quite difficult because 你請個人都要錢㗎嘛。But if you are very poor, then it's easier. 你攞綜援咧可以申請工人，但係咧你如果唔係，即係有啲錢嗰啲咧就最慘，你又請唔起，又攞即係社署又俾唔到佢，即係最慘嘅。So what I want to illustrate is sometimes the social support is important for the rehabilitation. So even if you train, walk like this, at home, no one help her, then she can only lie on the bed. Okay, so it's not very, I mean, you achieve the goals, but actually no one can continue with your goals, and it is a bit of wastage, okay? We will do some advanced training like stair walking, stop walking, getting up from the ground. Getting up from the ground means actually not using the prosthesis at all. Okay, so you just push with your good leg and hands and then move up, or you push on the wall. So this is the MMRC downstairs. We teach or train with the patient how to cross the road. Okay. Of course, we do the stair walking. After doing stepping exercise, if it's okay, then we do some stair walking. 呢個冇乜特別嘅，都係上落嘅。 Well, we will talk about this in the tutorial, okay? But this patient, the operation is quite special. We will have a look. Slow walking. So you main thing is you won't ask the patient to put the whole foot onto the ground. So when the good leg go forward, then it will step onto the floor. So 即係落地嗰下淨係腳踭落地，如果唔係咧，佢會北球，所以一定係啦。Okay, some care teach the patient not to use too hot water to do the shower. So it's just warm water. Because even 1 year later, the stump may get swollen and the size may change throughout the date. Still, because this is only soft tissues, not very rigid. It is just skin and then some muscles inside. Okay, so the shape of the stump may still change. Okay, so any questions? No? Okay. So after they go back home, our role will be help them to go back to their work. So it really depends on what is their previous job. If like the patient is doing some office work, okay, sedentary worker, then obviously it won't affect too much, okay? So even with wheelchair, you can go back to office, okay? But if you are a construction site worker, then it will be very difficult, okay? So just now the patient walk, I mean the hip disarticulation articulation patient, okay? He is a 保險經紀嚟嘅 okay? So it won't affect, okay? Even he can say 哇我買咗個保險就哇而家有得保障啦咁樣係咪 maybe a good thing for him, okay? Yeah, but for other may not be that case. Okay? So this is a patient with shoulder disarticulation. So I teach the patient to win. Okay. But I give him a float over here. You may see that's the blue one. And you see the patient don't want to come out and breathe. Actually, this patient, he knows to swim before the amputation, okay? But after amputation, only amputate the left upper limb. He told me that if he do in soup, like prone line or just prone in water, then he won't be able to stand up with this kind of level of water. Maybe the body orientation already changed. I can't imagine. 佢話俾我聽，佢瞓咗喺度咧係唔識企起身，所以最初係要佢又唔敢整個頭上嚟啦，咁佢整唔到上嚟，咁咪要俾個嘢咁樣 float 就 float 佢。佢後尾就好。即係唔係做戲嗰啲做戲嗰啲咁樣收隻手喺後邊，你咁樣收隻手喺後邊喺度游水，你唔會覺得我企唔翻起身嘅嘛？但係佢真係咁樣話俾我聽，係啊，咁啊，即係有時係真係唔同咗咯個 orientation。呢個就係 this is the young gentleman with the hip disarticulation. He is the Hong Kong TV. 有冇睇過呀？好搶手啊！呢個，因為咧佢哋計分㗎嘛，佢啲分即係咧，in a team there is a mixture of athletes with different level of disability, but his disability level is high, but the ability is also high. So 即係你同一隊裏邊要計分就即係佢又好搶手咯，即係同埋即係唔同嘅 different sports may want to ask him to come to join because of the good physique. Okay, so go sailing, go climbing, 有冇玩過攀石 ？Yeah, this one they only 3 limbs. We got 4 limbs also quite difficult already, so he can climb up. Okay, sometimes we will do some sharing session. So some like patients with some more experience can come back and then share their experience to those who just got amputated. Okay, so he was sharing how he went to UK for a trip. So this is quite old general, like around 18 years old. So they just share, and then sometimes it reminds the inpatient something they really never think of before because they just got amputated. They don't know what will happen after. So we have this kind of sharing session, like sometimes give them some insight. Okay, some more outcome measures. AMP, LCI, 6-minute walk test. Okay, so 頭先嗰個啦，即係LCI actually is 0 to 42 points. Okay, so this is you ask them some functional 14 functional activities, and they just tell you whether they need someone to help, someone near. It's a self-perceiving kind of questionnaire. It's the patient give you the answer, not objective. You measure. Okay, so sometimes you need to know whether it depends on the patient's perception whether they can do it. Okay, sometimes it may not be very objective, but still we will use it. But we can compare, of course, at the early stage of the rehabilitation and after a period of training, what's the difference, okay? 6-minute walk test, also the same. So you just ask the patient to walk 6 minutes, okay, with their usual aid, okay? Maybe some patients will use frame, some may use stick or elbow crutch. Okay, so of course we won't be able to rehab the patients on our own. We need to get help from other professionals. Of course, P&O is very important. If you don't have the prosthesis, you can't train the patient, isn't it? Okay, so occupational therapists look at their occupational need. Clinical psychologists depends on whether the patient has some emotional problem. Like just I said, if the patient got necrotizing fasciitis, the foot is amputated within less than 1 day, sometimes it could be very traumatic for them. Or a patient with traffic accident. Okay, so I have an old lady got 即係俾個巴士個碌過咗咁樣 amputate. Okay, so that must be very traumatic. Okay, and then social worker depends on like just said if some patients really need some social help. Okay, social support, then will involve the social worker. Okay, so let's talk about the other surgeries. I would like to talk about 3 surgeries. We go through it quickly. So rotation, rotationplasty. Before we talk about do it like this. So it's basically like if the patient, the femur is not, it has this osteosarcoma, okay, disease form, you need to remove it. So we move the tibia to the hip joint or around the hip joint. So the knee joint become the hip, okay? So this is the real case, okay? So the ankle joint actually become the knee joint. I saw around 3 cases like this. Okay, so 2 is older, 1 is quite young. But that one, I mean, after surgery, passed away 6 months later. Very, very weak patient, a younger and weak. But this patient is a bit older, around 65 years old, but he lives in anyone know, very many slopes, many stairs over there. So actually, you can imagine if the patient got hip disarticulation or can walk with this one, maybe a bit different. So this is just now you saw a video doing stair walking. Actually, this patient can walk upstairs. At least 出街咯，你咁多斜路用 wheelchair， 因為你唔會調過去。原來係要嚟。You need to have very good plantar flexion range. For 70 degrees of plantar flexion. Okay, so another surgery, the targeted muscle regeneration. So what it is, targeted muscle regeneration? It basically means when you amputate, the nerve is cut, so you find a muscle that is not very functional to branch into that muscle. Okay, why we need to do this surgery? Just now I talked about a patient who was very painful when the doctor assessed. Okay, so why she need that surgery? If the nerve do not have a clear target to regenerate towards, so means this one, you cut, nothing attached to it. Okay, so we just usually before we just put it underneath the muscle. Okay， 即係等佢唔好咁樣條條揈嘅，咁揾個 muscle 攝住佢，咁啊即係等佢唔會喐嚟喐去咁樣啫。但係咧 ，but it may regenerate into a disorganized mass like neuroma, so you got phantom pain. Okay, the TMR provides nerve ending with a muscle. Okay, so you reattach to a muscle. Okay, then it regenerates in an organized fashion. Okay. And then it also improved the ability of the patient to use the prosthesis. Why I said so? So if you have a prosthesis, different areas can control different fingers. Okay, then you can have more function. Like you can do different grips. Okay, you can put a thumb arm, you can pincer grip, tripod grip, any kind of grips. Not what I've just said. You can only have hold and release. Okay, so that one not very functional. This one much more functional. But how can I do this? I need to have more EMG input. So that's why they will split the pec major into 3 different portions. So they have upper, middle, and lower portion. Okay, so that can control different things. So you can do much more functional movement of the limbs. Okay, so just now we talked about the myoelectric prosthesis. You need to have this because if you have only one pec major, you can either have EMG or no EMG. Okay, so you can maybe you can do have EMG, you grab, and then without EMG you release. Okay, but you split it into three. With the pec minor, with the latissimus dorsi, you have 5 muscles input. You can have different patterns of EMG. Okay, so you have much more functional movements of the upper limb. Okay， 即係可以用嘅機會就大啲咯，即係 more functional。Okay. Okay, any problem about this? But another thing is the main idea at the very beginning is to control the prosthesis better. But the side effect is that they found that the the phantom pain much more decreased. So that's why in Queen Mary Hospital, they nearly all the amputees right from the beginning, they will do the TMR now. They don't want the patient to suffer from a period of phantom pain, severe phantom pain, then you cut it off again and then do the TMR. So they want this surgery to help to decrease the phantom pain right from the beginning. Okay， 即係你橫掂都cut 啦，不如喺裏邊整埋，即係駁埋個 nerve， 其實好快嘅。Okay, so that two purpose. Okay, so the pain control is accidentally they discover and then they promote it now. Okay, the last surgical technique, osteointegration. Now in Hong Kong, there are 2 patients in Queen Mary received this osteointegration. This part, okay, you will see will stick out forever. This metal part. Okay, so like from here, this part is subcutaneous, so it is stick outside. Okay, but you can see from the X-ray, this one is the normal prosthesis. Normal prosthesis, the femur is like this. Okay, but with an implant called osteointegration, actually the implants stick, push into the femur, and then the force can transfer through the femur upwards. Okay, this one actually you just depends on the soft tissue, not very rich, just soft tissue stump of the stump. Okay, so it will not actually weigh better on the femur. Okay, it provide a direct metal to bone anchorage. Okay, so actually is provide greater mobility. Okay, it's good for some kind of patients. Maybe we look at this example. But you can see because it stick out from the skin to outside, you will see at the beginning many discharge. Okay, chance of infection. Usually, nearly all patients have infection, but usually can be controlled by oral antibiotics. So it's okay. Around 1% can be managed. This one need to take off. This is the data from Australia, but Hong Kong now only we've got 2 patients. Both of them are okay now. So this is a lady who we have in our center, 42 years old, AKA, and then can only walk for 5 minutes. Okay, 5 minutes means actually you can't go outside. You go to shopping mall, you can walk only 5 minutes, then you need to remove the prosthesis. So actually she can't, actually same like can't walk with a prosthesis, isn't it? Okay, so mainly go outdoor with the wheelchair. and then walk with 2 elbow crutch without prosthesis at home. Okay, so this is how she walked before the operation. Actually, she can walk quite fast. With the old prosthesis, I mean, that one is before the operation. But the problem is, 5 minutes later, we need to take off the prosthesis. Okay. 都幾快喎，其實好後生嘅事。Okay. So after the osteointegration, this is how she put on the prosthesis. Okay. Okay, it's put on. But she is not doing the the knee flexion. Okay, normal gait. So I try to train the knee flexion and toe roll. So I just break the whole motion into different pieces, and then I just train and adding more components afterwards. So 而家係咪有少少 knee flexion？ 係啦。Then use one elbow crunch. Okay. So this is later how she walk. She's walking the dog actually. And actually, before he walked her dog with a wheelchair, so the dog is not very happy. 1,000 steps. Okay. Sorry, 10,000. 即係行到一萬步，你諗下幾 ？Before only 5 minutes. Okay. How can go hiking? Okay. She is a Korean, live in Hong Kong, so 啲國技係啊國技啊，哇！住喺屋企嗰度食。Okay, but you can imagine if But the main thing is, if you need to have accuracy, you need to have very good stability, isn't it? So if you have normal prosthesis, you just sit on some flash, okay, 即係都係厚㗎嘛，咁一定冇咁穩陣咯，係咪 ？And then later on, she go gym every day, so you see how much weight loss 係咪？之前好肥。Okay, this is how she come back 1 year later. 考唔考到啊？我冇同佢考，因為佢喺佢啲飛咗翻學個特訓啊，佢要訓練，佢要入 Paralympic 嗰個韓國隊嘅備戰啊嘛，所以呢個係韓國嚟嘅呢個。 So when she come back home, I just ask her to do some walking. I can WhatsApp 問下佢先。
佢就長嚟香港揾你。
係啊，即係佢翻嚟，係咯，翻嚟咪探下我哋，即刻影下。好啦，咁啊 ，so this is the summary acute phase. Do some functional training, desensitization, exercise training, some edema control, very important. So you have to measure the prosthesis as early as possible. Okay, and then the prosthetic phase can do PPAMA, so that pneumatic pylon. Prosthetic phase, we will talk about this tomorrow. Okay. Next. Vocational phase, the sports rehabilitation and return to job, outcome measures, AMP, LCI, 6-minute walk test, other surgeries, rotational party. You remember the limb rotated, targeted muscle reinnervation for pain relief, and also for some kind of more functional upper limb prosthesis, osseointegration. In Hong Kong, we have 2 patients receiving quite big difference. Another 另外一個咧都係巴基斯坦嘅，兩個都唔係中國人，唔知點解。咁啊可以送外賣啦，做完之後，一做翻送外賣，即係嗰啲車好快嘅，係咪可以做 ？Before can walk, can only walk for very short.
Somewhere basic.
Okay, so that is